Welcome, everyone. My name is Jen Sharon, NHIA's Chief Operating Officer and your moderator for today's third in our COVID series, the emerging use of telehealth and virtual work environments in home and specialty infusion. I'd like to take a moment to thank our generous sponsor of our COVID series, McKesson, an NHIA Future of Infusion Advisory Council member and NHIA Gold member. We have Bonnie here from McKesson who would like to say a few words. Bonnie?
Thanks, Jennifer. Good afternoon, everybody. My name is Bonnie Jalanowski, and I'm the Director of Product and Portfolio Management for McKesson MedSurg. I'm excited to be here today as a sponsor for NHIA's webinar, The Emerging Use of Telehealth and Virtual Work Environments in Home and Specialty Infusion, especially with how the healthcare industry has evolved with COVID. McKesson is a leading distributor of infusion therapy supplies, devices, and pharmaceuticals, as well as technology solutions around asset management and patient engagement. We understand the needs of our customers and our own needs are changing in this new environment, and utilizing tools to work and connect with patients remotely will be critical for future success. We so appreciate the partnership with NHIA and all of you, and we are excited to sponsor today's webinar, but I'm also excited to hear today's speakers, and I will turn it back over to Jennifer.
Thanks, Bonnie. We truly appreciate McKesson's support for the home infusion industry and the entire COVID series. Building off the success of NHIA's summer series, the NHIA education team created a star-studded lineup of COVID-related education to be held each Thursday from 12 to 1 Eastern Time for the month of October. Make sure to watch the Infusion Express for upcoming sessions and registration links, or visit NHIA's new website, click on Learn CE Education COVID Series to register for future events or catch up on anything you missed. Just a couple of housekeeping reminders. The presentation is available for download from the handout section of the navigation pane, as well as the speaker bios. The webinar will be recorded. A link to the recording will be emailed to you following the conclusion of the webinar and will also be available via NHIA's website within the next 24 hours. In order to receive CE, please follow the link in the follow-up email and answer a short quiz. Following the presentation, we will have time to answer your questions. Please submit your questions via the question tab in the navigation pane at any time during the presentation. Okay, now on to our presenters. Joining us today to share their experience is Don Philibek, Felicia Shops, and David Hurst. Clearly, a star-studded panel helping us understand more about the telehealth options for home infusion. More information about our speakers can be located in the handout section of the toolbar. I know you all have a lot to cover, and I'm going to hand it over to Don. Don?
All right, well, good afternoon, all. Welcome to this hour of hopefully some takeaway information. Welcome to my den in Dublin, Ohio. Again, it's where all of us seem to be working now. A good chunk of us probably on this call working remotely. So again, welcome. I'm going to set sort of the foundation for David and Felicia when they bring in some of their perspectives. And it's really what is happening now from a regulatory and licensure perspective that allows, for example, what David's going to talk about, remote visits, and then Felicia talking about actually working remotely. Because again, unless you're able to do that legally, you're really sitting in an office. So with that, next slide, please. Little bit of background. This shouldn't be anything new to you, and it's hard to believe that we've been dealing with this pandemic and this state of emergency we've been in since the end of January. That's almost 9 months. Don't know where the time has gone, but again, the president declared that state of emergency, or actually formed the coronavirus task force on the 29th, and then a couple days later, that declaration of public health emergency was declared by HHS, and that went retro back to the 29th. That declaration by HHS allowed states to really kick in their emergency procedures, declarations of emergency, and all the things that allowed them to do. It gave the states greater flexibility, and a number of other governmental entities the flexibility to do what they needed to do by declaring emergencies. Again, when I talk about waivers of laws, boards of pharmacy, boards of nursing started kicking in waivers to existing rules and regulations. So it really did kick in that ability to adapt and change to what was going on. Again, as we all remember, there were a fair number of Americans who were overseas, and with the countries clamping down the ability to get out or into a country, our State Department really kicked in and got those people home. there were collaborations with manufacturers and all the things that really kicked into gear. So really started the ball rolling. The website that you see on the bottom of the slide is put together by the National Governors Association. And Ryan, next slide, please. This is an example from that website, and this has been updated. It was updated as of the 9th this month, and it really gives you a history of where this declaration of emergency is from state to state and where they are in the process. Some of them have had a numbers of extensions to their declaration of emergencies. Some are really getting close to expiring. And you have to think about when the state's declaration of emergency expires, all those waivers that boards of nursing, boards of pharmacy, whatever have put into place may go away. So you have to be prepared that here in Ohio, we allow remote pharmacy practice. It's based on the declaration of emergency. And if for some reason that would end the end of the month, those individuals who are practicing pharmacy remotely, whether they're a pharmacist or a technician, would have to come back into the office, and you would have to now think about, how am I going to social distance? What protections do I have in place? How are they going to clean their cubicles? All those things that you have to think about. So it's a great website. I happened to stumble across it. So again, I would encourage that you click on that link in the reference and take a look at it. Next slide, please. Again, the FDA certainly was responsive. Again, we all have our pros and cons about the FDA now and there. And the CDC and a couple other governmental agencies, and this isn't a political commentary, but again, they really did start out, they accelerated the manufacturing of equipment. We remember Ford making ventilators and Ford making face masks, and number of car companies doing what they needed to do, really pushed that process forward quickly. Again, they were monitoring the medical product and food chain supply chains to ensure that there were no major disruptions, that the quality of the food we were still getting, the quality of the products we were still getting was where it needed to be. Again, there were a number of, if you were like me, you got a number of spam messages, things popping up that were selling everything from masks to you name it. And again, the FDA tried to keep that under control. Later in the year, August, they brought in the scope of the EAU for remdesivir. Just a comment though, that remdesivir is still not allowed for use in the home. It is strictly limited to inpatient setting. We've had a number of requests, can we do it at home? I can't obtain it, and it is still technically by the EAU limited to use in an inpatient setting. Again, they've had some other EAUs, and again, they've offered a number of guidance documents. So again, you can certainly go to the FDA website or any of the government websites for more info on that. Next slide, please. The DEA also weighed in. Certainly, there were a lot of governmental agencies that weighed in. Again, one of the requirements typically of prescribing controlled substances is that there does have to be a physician-patient face-to-face interaction. We were avoiding the telehealth website prescribing of controlled substances, especially Schedule IIs. Again, they did relax that requirement. So again, a physician could prescribe a controlled substance, again, primarily Schedule IIs for patients without having that face-to-face interaction. Again, we had been dealing with shortages of controlled substances off and on throughout the last few years just because of the FDA's clampdown on manufacturing. COVID certainly precipitated an even greater or tighter supply. So again, the DEA ensured that the products were still coming to market. They've got a fair number of guidance documents out on their website also. And again, one thing they did relax, and the pharmacists on this call should be familiar with this 5% rule, which is basically the transfer of controlled substance from one DEA license holder to another DEA license holder. There's always been this 5% rule of the ability to transfer. The DEA did relax that, and I believe it's still relaxed. I'm not 100% sure on that. Next slide, please. USP also weighed in. Again, their first comment was make sure that protective PPE was reserved for direct patient care personnel. That again, while important being used for sterile compounding, our frontline healthcare workers, nurses, respiratory therapists, whomever that might be, had the PPE that they needed. Again, they prioritized the availability of sterile gloves. They did suggest that, again, in large compounding facilities, that you limit the number of people that were going in and out of the clean room, because, again, typically that would help conserve sterile gloves, masks, gowns, shoe covers, things that typically we're gowning and garbing with when we go in and out of our clean rooms. They established and how to document deviations from standard operating procedures. Again, all the pharmacies on this call had ways they were using their PPE, from how often whether you reused it or not, when it was discarded. So again, they offered guidance for the use of GARB required that. And again, once USP weighed in, the states also weighed in. So for example, if you were using face masks, while there was some conflicting information between what USP said to do and then state boards said other things, basically if you were reusing masks, there was a way to protect its integrity by placing it into, well, we ranged from plastic or brown bags to boxes to Ziploc containers, all kinds of things. So there was some conflicting information. Same with gowns. They relaxed the requirement that gowns be changed each time. And again, if you were reusing gowns, what you needed to do that. They just did issue some periodic guidance. The last that I've seen was back in May. So again, if you're not familiar with that. Next slide, please. Individual state responses, first of all across the board. There was no consistency in what states decided to do. There were states that very aggressively and very quickly put waivers into place, thought about remote pharmacy practice if it hadn't been allowed by state law, thought about the reuse of PPE when it came to sterile compounding, thought about what pharmacies could do to social distance and all the things that we were being told to do. And then there were states that basically were silent on the issue, didn't weigh in, didn't change anything. And so it ranged from do what you need to do, here's the law that will let you do that, or the waiver on that law, to we're not gonna change how you practice pharmacy in the state. So, and then it still exists to that day. There are some states that have never really, from a board of pharmacy practice, addressed COVID and the pandemic. There were a lot of waivers put in place, from reusing PPE, remote pharmacy practice, and that's basically where I, for example, sitting here in my office in Dublin, could practice pharmacy by logging into my dispensing system and calling patients, filling prescriptions, printing out that documentation in the pharmacy, doing what I needed to do. There are states that are very, I'll use the term liberal with that basically both pharmacists and technicians can do that. Some had already had existing laws allowing that. Many states did relax that having to be in the license space requirement. So again, that practice was able to be done. Counseling requirements, again, because typically if you remember going to pick up a prescription at, say, my Giant Eagle, I always signed on the keypad or the pad that I waived my counseling rights. Well, now I couldn't do that because the Giant Eagle store didn't want me touching that signature pad, so they basically just said I declined. So that some of those counseling requirements, signature requirements, again, remember the payers kicked in on that. The need for signed delivery tickets, Medicare weighed in on the need for signed delivery tickets, emergency refills, training requirements. So again, as technicians, for example, we're marching through becoming certified or registered. Some of those training requirements were relaxed or postponed. Same with licensure renewals. There were a number of states that if your license was due to expire in May, they gave you a period of time to try and get that license renewed, because typically the state boards were dealing with people not being in the offices. So again, their staff was down considerably. And again, so they relaxed those Same with licensure requirements just for facilities. The little screenshot in the lower right-hand corner is a website that I stumbled across in all of this. That's the reference noted on this slide. It is an excellent, excellent reference of where the state boards of pharmacy are in their rule and regulation waivers, when they declared an emergency. So again, I would suggest you click on that link. It's a law firm. It's public knowledge. It's just on their website. It's maintained. It was last updated the 8th of this month. So again, it's fairly decent. I refer to it fairly frequently. And again, there's a lot of links in there. So again, I can click on the link and then go directly to the Board of Pharmacy site, website, or whatever the case might be. So next slide. NABP, in order to help support the movement of pharmacists around, put in place this passport program. Again, it was a temporary emergency licensing program facilitated by NABP, and the passport program. It allowed boards of pharmacy, for those who participated, to assure that I had a valid license. So for example, North Carolina is a state that used the passport program. I don't hold a North Carolina professional license, but if I had the passport license, basically the board, NABP validated that I had a pharmacist license in good standing, and that would allow me to practice in the state of North Carolina without actually having a North Carolina pharmacist license. There are currently 13 states. There were more at the beginning. This program is slowly winding down. In fact, they stopped taking applications effective the 1st of October. And the program actually today is slated to go away the end of the year. Now that may change. NABP may, and the boards of pharmacy may decide to keep that longer, because it doesn't certainly appear like COVID is going away. So, but today, if you happen to be part and practicing under this passport license, that license would technically be null and void come the end of the year. And that I would suggest, if you're not seeing this, to check that out. Next slide, please. Quick screenshot of what that looks like. There's the states that, as of the end of September, recognized the passport program. There are a number of states where that recognition has expired. So again, FYI there. Next slide, please. From a nursing perspective, again, the state boards of nursing were just as bad as the state boards of pharmacy, all the way from they relaxed waivers, they allowed nurses to practice with licenses, and this is outside of the nurse licensure compact agreement, would allow nurses and other healthcare professionals to come in and practice without holding a state professional license, but it did vary all across the board. From a nursing perspective, nursing has had this nurse licensure compact agreement, and sorry for the graphic being really small, but that was taken right off of the website referenced here, number 10. Those states in the dark blue are states that participate in this NLC or ENLC licensure program. So basically, if I hold a nursing license in the state of Kansas and I need to go up to Nebraska to practice nursing, my Kansas license allows me to go into Nebraska and actively practice. It's a basically sharing of licenses. So that nurse in Kansas doesn't have to have both the Kansas license and a Nebraska license, and a North Dakota and a South Dakota. As long as they live in a state that participates in the compact licensure program, they can practice in those states in the dark blue. Some of the states are that lighter teal colored. I believe they were in process of legislation to participate in the compact program, and obviously the states in gray don't recognize that. So if I live in Illinois and would need to go out to California to practice, unless the state waived or relaxed the licensure requirements, I'd have to get a California nurse license. And you'll see other things for other professions. So I'll move on from that. Next slide. Just a couple other quick resources. Certainly NHIA has a wealth of information on their website. I'll just direct you to that. ASHP also has a wealth of information on their website. And the one document that I probably use fairly frequently is the first one listed there. It's the enhanced table I'm sorry, evidence table. It's actually been updated again as the 8th of October. It lists all the treatments that are available out there for COVID. It's an excellent, excellent document. So if you've not seen it, it's free. You don't have to be a member of ASHP to download that evidence table. They've got a great catalog of resources. They've got a diagnostic testing chart. So if you're confused between rapid testing and TLC and RPG testing, it really does a nice job of going through all those various and sundry tests. And then it also has a really nice article on just COVID vaccines in general. So again, two very good websites. Both have slightly different information, both very valuable information though. Next slide, please. Finally, what can you do? Again, if you're make sure you are aware of where you are in those waivers in your state from a board of pharmacy perspective, board of nursing perspective, because again, they're constantly changing. For example, Illinois, every month they extend the waiver. It gets to be the 23rd hour and we're still waiting for the state to basically say, yeah, we've extended it, then all of a sudden they extend it. California is very similar, and some of their waivers are sort of going away. There's no sequence to it. All of a sudden you'll realize that waiver is no longer valid. So if you are actually using that waiver, there is a way to ask for an extension, but you got to realize that all of a sudden you may not be practicing within the law. So keep up with the state, not only that you may be residing in, but any of those states where you might hold non-resident pharmacy licenses or whatever the case might be. Keep up with travel restrictions. Again, as your employees start getting really stir crazy and decide, I'm going on a trip, and they happen to go, and I'm going to pick on Wisconsin, and I don't mean to offend anybody from Wisconsin on this presentation, this call, but Wisconsin has just blossomed with COVID cases. And again, many states are saying that if you've gone to Wisconsin for any length of time, when you come back home, you need a quarantine. And that's the 14-day quarantine. So I may innocently have gone to visit mom who lives in Milwaukee, gone back to, and I don't know if this is the case, gone back to Illinois, and now all of a sudden, if I'm not a remote worker, I'm not working. I'm on a 14-day quarantine. So keep up with those travel restrictions. People are getting stir crazy and people are starting to travel. And especially with the holidays coming up, it may be problematic. Felicia's going to talk more about remote employees, but adequate access, they're protecting PHI, patient conversations. Again, if I'm sitting here in my den, I want to make sure that it's quiet, it's private. Again, my wife is home and technically she shouldn't be hearing these conversations, so you got to be cognizant of that. And again, are people being productive? Again, it's very easy to get distracted at home, to walk away from your computer easily. So again, Felicia will talk a little bit more about that. I think I have 2 more slides and then we'll turn it over. This is just an example of a spreadsheet that I put together to track all the various states. When was their declaration of emergency? When do the waivers expire? What can a pharmacist do remotely or not remotely? Technician, what was their stance on PPE? It's just it's a spreadsheet I put together. I put some pivot tables in there so I can pivot and look at it. It's just a tool that I developed to keep up with it because of who I work for. And the next slide. And finally, this was just another spreadsheet we put together to help us manage the travel restrictions. So again, we would look at a state and who are they basically saying can't come back in, or if you come back in, you have to quarantine. And we update this periodically, and when we get those travel questions, we're going to refer to the spreadsheet versus trying to go to the website and develop that all over again. So I believe that is it. And with that, we're going to turn it over to David.
Thanks, Don. My name is David Hirsch. I'm from the Johns Hopkins Home Care Group. So we're going to talk a little bit about telehealth and home and specialty infusion. So next slide. So a little bit about telehealth. Basically, telehealth defined as a method of providing medical support when face-to-face is not possible by using information and communication technologies when the provider and patient are distances apart. That is not to be confused with telemedicine. Telemedicine really is kind of the encompassing teleeducation, administrative, non-clinical services, along with that telehealth incorporated in there. And you can see really where the concept of telehealth started, believe it or not, all the way back in 1876 with the first telephonic consults by Alexander Graham Bell. And it was related to a patient who had an acid spill. So looking through as we moved into the 1900s and 1940s, transmission of the first medical videos, images and radiography occurred. 1980s was really when radiology embraced telemedicine and started digitalizing their images, up into the 1990s and 2000s to the present, where we have expanded with mental health disorders to applications across primary care and varied specialty services. Next slide. So what's driven these telehealth advancements? So really there's kind of three different groupings that you can kind of look at. So advancements in technology, so everything from your telephone through television, radio, picture, videos, the World Wide Web. Your primary or your other advancements include memory and storage that we have capabilities on our computers and our devices. Standardization of file types. Security is a big one that's extremely important, making sure that your connections are secure. The development of applications on our phones, cloud and virtual servers, advanced digitalization through the use of cameras and scanners. So all these were advancements that have impacted the telehealth. Some of the limiting factors that are important to also keep in mind is how easy is it to use? So if they're complex and difficult, you're going to have more problems. How reliable are they? Are they stable and safe for use? Again, looking at those safeguards and security. And then what is the availability of the technology for the average Joe out in the community? So next slide. So what do some of the advancements look like to us? So in telehome care, as you can see, most of our advancements fall under this other advancements category. So smartphone technology is a big one. There are so many different health-related applications that you can actually go in and download for free onto your computers or your cell phones. The electronic medical record systems and the ability for those electronic medical record systems to have apps for patients to use as well as for our employees to use. Different communication apps. So it's unbelievable how many different ones are out there. Everything from Zoom to Microsoft Teams are ones that we see a lot in my practice. Other things such as other applications, your pulse ox, your heart rate. Nowadays you can download apps where you just put your finger over the camera on your phone and it'll tell you what your heart rate is. It'll tell you what whether you're in sinus rhythm or not even. It's pretty amazing, some of those advancements. And then picture and video capabilities are also extremely important, and being able to utilize your phones to upload information directly into the medical record. So all those kind of impact the ability for telehome care to exist. Cloud services is the next thing that's important to keep in mind. So the ability to save those documents and resources and access them again remotely. The ability to access large amounts of information easily from just a cell phone. Connectivity is important, making sure that you have that connectivity and it's a stable connection. And then being able to have multiple users in that system at the same time is important. So next slide. So again, looking at security under other advancements. So PHI, so protective health information, and having the ability to make sure that HIPAA is maintained is extremely important when you're using these applications. So keep that in mind. The ability to for an organization to manage a clinician's phone remotely. So that's the other part. I know with our organization, our phones are being monitored and are being watched. They have the ability to wipe those phones clean from any remote location in order to make sure that patient information is protected. And then that advanced digitalization again. So digital phones, digital cameras that improves the quality of images that we take. Using those images and uploading them into the medical record system in a very quick and accurate way. And then the ability to do video phone calls from your cell phones or your computers is extremely important. Next. So we have a couple goals when we're applying telehome care to our patient care. So our first goal essentially has been the goal of limiting potential exposure of our staff to patients and vice versa. So we're looking at decreasing the number of visits that we're conducting or decreasing the time that our clinicians are spending exposing patients or being exposed to patients in that home setting. So we look at this from a couple of different angles. So we're looking at this by eliminating in-person visits by providing virtual support. So we really want to look at where do we have the ability and the capability to say we don't have to have a nurse face-to-face with that patient in the home, and therefore we are eliminating exposure. So what we did with my organization is we actually looked at it from a couple different angles. So the first thing we did was we started looking at what therapies can we make sure and mandate patients become independent in their care. Things like your chemo takedowns, looking at how many visits does it take for us to get a patient independent? How can we teach them? And for those patients who are having difficulty learning, do we need to have a nurse there at the bedside, or can it be done virtually? So we started looking at those first. We looked at our on-call complications. Sometimes we're sending nurses out to the patient's home when really, do we need to send a nurse out there? Or could it have been completed during a virtual visit? So we're looking at ways to utilize that for those troubleshooting issues. We also even did our first IVIG titration with a patient. So we had actually a patient's caregiver who was a clinician, and we compensated on being able to place that peripheral line, and our nurse was on virtually on the phone or on a camera visit with them, and actually walked them through the titration up and administration of their IVIG very successfully without any problems. So those are some of the things we looked at when we're looking at eliminating in-person visits. Next slide. So then we started looking at ways that we could start minimizing time and face-to-face with our patients. So we did this in a couple different ways. First off, we looked at ways that we could provide the virtual in-person or virtual versus in-person visits, a combination of the two. So what we had our clinicians begin to do was, when we had visits scheduled with them, if there were patients that were at high risk, or patients that were patients under investigation, or even positive patients, we would have the clinician drive to that patient's home and start the visit from their car. So we identified what aspects of the visit could be done via a video call, and some verbal communication assessment, as well as just visualizing different aspects. Everything from your medication reconciliation through to doing some portions of the head-to-toe assessment, really we could do virtually. So we would have the clinician perform those components from their car, and when it was time for them to actually go into the patient's home and do hands-on care, they would then gown up, put all their garb on outside the patient's home, and enter the home. That way we're minimizing the amount of exposure time that both are having to each other. We also initiated a virtual started care process. So we had an office-based clinician that we had been able to actually coordinate all starts of care, go through that clinician, and they do a phone call and a virtual visit with that patient and complete a lot of those components that we can do verbally or visually via that process. So that was another important step that we took and have recently been able to roll out with our patients. The last thing that we looked at really was our titrate up and go. So I spoke to IVIGs just a moment ago, where we were actually able to have a patient caregiver do the actual IVIG infusion on their own with a nurse on the phone. So the other component that we're looking at specifically for those long visits is a titrate up and go process. So what that means is that our nurse goes and sees the patient, titrates that up to the patient's maximum dose of IVIG, and as long as they're stable and we have an order in place, we're able to actually leave that patient. They have been compensated on things to look for as far as any types of reactions and how to manage those. And then there's a phone call that's made at the end of that infusion just to validate everything has been completed without any complications. And that's worked very well for us as well. Next slide. So some additional best practices that were mentioned that I wanted to bring to everyone's attention. So there's your remote patient monitoring. So there's a lot of different technology out there that can be used with remote patient monitoring. Really what that is, it's the use of artificial intelligence to collect patient data and digitally communicate that information to centralized team members. So we really kind of look at our individual practices and what's the best way to apply that remote patient monitoring to our patients. There's tools that are used, anything from things that they wear on their body, the watches, so your smart watches have some components of that. There's also different types of tools that go right into the internet from a patient's home, where they actually do it every morning and they answer specific questions. So really kind of look at what is the application, how can it be used, and what are you going to get out of that, okay? It can help prevent ER usage, help prevent readmissions, and help identify things early on in the patient's care. Next slide. So whenever we're looking at the health and well-being of our team members is the next thing that we need to consider, that we need to make sure that any strategy that we use to focus on the well-being of our staff also focuses on the well-being of the patient. So we're looking at those hand in hand. I know with our team, our employee safety is right up there with patient safety. It's extremely important we take that as paramount. So some of the strategies that are important to keep in mind. So expanding nursing education as it relates to the use of technology. So one of the things that I've learned over the years, and being a nurse myself, is that nurses are very patient-centric, as I think we all know, and most healthcare providers are. So we're going to put ourselves right smack dab in the middle of any issue a patient has to try and solve that problem and prevent any additional problems from occurring, right? So that means most of my nurses are going to look at, oh, there's a problem, let me get out there and take care of it. I want to fix this for this patient, make this patient happy, make them better, okay? So we want to make sure that we are preparing our clinicians so they're not jumping to do that. We want to make sure that they're using technology to their advantage and that they're comfortable to use that technology such that if they have a problem with it, they know how to get it fixed, or they know who to reach out to get it fixed before they just jump to go in to see that patient, okay? We want to make sure our clinicians are well-versed and capable of using it is the bottom line. Next slide. So again, minimize patient-caregiver interactions with members of the team. So that's our second strategy. So we had full virtual visits, we had partial virtual visits, and a virtual starter care, which we identified most of them through earlier in the presentation, but that's just basically how we have it broken down. It's our full, partial, and virtual. Next slide. Minimizing non-clinical staff interactions is the next thing that we're going to do. And Felicia is going to take this on here in a second, but I'm really kind of looking at the work from home strategy with our team members, making sure they have the infrastructure, technology, internet bandwidth was one of the things that we had a lot of conversations with our central IT and our employees with. Having multiple screens in the home can be the difference between them being productive and unproductive. We want to make sure that the furniture in their home promotes healthy activities. So one of the things we do is we have them take pictures of where they're going to work from to make sure they're not going to be injuring themselves sitting on a ball or something along those lines. And then have the proper telephonic support is the other component. So we use a system called Avaya to make sure that staff aren't using their home numbers or even their personal cell phones to call patients back. And then those patients have those telephone numbers and calling them back at all hours of the day and night. We want to promote a healthy work-life balance. One of the things I learned was when I first started working from home, I had everything set up in my living room with television on, and I was working from that perspective. And I found that all hours of the day or night, if I was sitting there, I'd be tempted to open my laptop and start working. So I really kind of had to separate out my work location in my home and my personal locations in my home so that I go upstairs, go in my office, that's when I'm working. When I leave my office, I'm done for the day, I go back downstairs and I'm done for the day. I'm not tempted to go back in and start working again in the middle of the evening. I think I have one more slide left. And then assessing for failure to adjust is the other important thing. So we all have team members who thrive on that personal interactions and the social components of their work. We had the same issue with some of our staff as well. So we really want to kind of look at ways that we can help mitigate and help give them some of their social interactions, whether it's mandating video cameras on in certain meetings. We had everything from shifting staff members and their hours to shorter periods of time, promoting a healthy work-life balance by having virtual get-togethers. We had virtual happy hours throughout the course of a month where our staff are able to actually get on and see each other and talk. And maybe something as simple as what I called puppy palooza. So we actually had a number of us get puppies, and we were talking about this as a panel the other day. And there's some pictures of my new puppy. His name is Henry. But he's been a lifesaver for me during this time, to be quite honest. I think that things like that are extremely important, that we're taking the time to take care of ourselves and consider what we need to be healthy and to be able to take care of the patients that we care for. So that being said, I'm going to go ahead and hand off to Felicia.
All right, thank you, David. I'm going to shift gears a little bit and talk, tailing on to what David was talking about, protecting our office staff and who can work from home and who needs to be in the office. Next slide, please, Ryan. What steps are needed to protect our office staff is something that we really need to be looking at. And I want to remind you that anytime that we have an emergency preparedness plan, one of the first things that we evaluate as part of that plan is who's going to be available to work. So who can work from home? Who of your employees can work from home? Who has daycare issues? So, this didn't just affect our offices, it affected schools as well. And all of our children are home, and some of us have very small children, and it would be very difficult to be working full-time from home as well as providing daycare for those children. And as David sort of alluded to, who has internet available and who has an issue with internet? That's important if you're going to be working from home. You also want to evaluate which of your employees are at high risk. So who do we really want to be protecting? Some of our older employees may be at a higher risk of developing COVID, and maybe it's a better opportunity for them to be working from home, as well as those employees that have comorbidities and are at a higher risk. And then we looked at which departments we thought could effectively function from home and which employees we really still need to have in the office in order for us to be able to provide medication to our patients. And as Don mentioned, we need to look at the Board of Pharmacy regulations to see who has to be in the office and who's able to work from home. Next slide, please. So the departments that we determined were able to be effective from home were intake. They don't need to be in the office in order to put the information into the computer for a new patient and to run insurance benefits. Nursing staffing could effectively be done from home. Patient service representatives, or whatever you call them in your company, the technicians who are responsible for speaking to patients for supply refill orders or refill of medication and coordinating deliveries. Again, you need to make sure that this meets your Board of Pharmacy requirements for your state, but most of those employees can work from home as well. So can billing. So can your pharmacists who are processing refills and doing follow-up calls to patients. And department heads. You don't need your nurse supervisor or your, billing supervisor to be in the office. They can work from home. You really can keep a good eye on what's going on in your branch without actually being there. Next slide, please. So then who are we defining in your branch as the essential workers? So the Department of Homeland Security defined essential workers as anybody who conducts a range of operations and services typically essential to continue critical infrastructure operations. That's a huge term that can apply to healthcare. It can also apply to energy, police officers, anyone who provides critical services. There are 42 states that issued some sort of guidance on actually which sectors and which industries they considered essential, despite, patient needs or despite pandemic-related closures. So next slide, please. So who are the essential workers in your branch? Who fits this description for your branch location? We determined that, of course, would be the compounding technicians. They can't work from home. We needed more than one pharmacist in the branch. So one who was processing prescriptions, a second one who was checking mixed medications and double checking high-risk prescriptions, double checking pump programming and supplies going out to patients. So you need to have more than one pharmacist there. We certainly needed the warehouse technicians, the folks who were packing up the supplies and coordinating the deliveries and shipments. They also were managing our inventory, and we needed them so we didn't run out of supplies, which became a very tough job for them. Some of the last couple months, it's been hard to get medications and certainly the PPE supplies that we've needed. We mandated that field RNs and our drivers or couriers stayed out of the office. They were not allowed in. If nurses needed more supplies for their bags or their car stock, we shipped it to them. So they sent a list and we had the technician in the warehouse put that together and we shipped it out to them. So thinking about the fact that the nurses and the drivers are in contact with patients every day, we don't want them bringing back whatever it is that the patients had. So we kept them out. Next slide, please. Technical support was a huge part of whether or not employees could work from home. So in our location, we were able to pick up our desktop and take it home and set up at home with the desktop from work. It connected to the network and therefore they plugged into a cable at home, sometimes with the help of our IT department, and they really were able to connect to our pharmacy work center, and they could print in the office, they could fax into the office, and they had real-time information. So the remote pharmacists were able to process and print compounding documents into the office and pick tickets into the warehouse so that the warehouse technicians could pull supplies as needed. The pharmacy electronic medical record could be accessed by the remote employees, and therefore they could document. They also could take information from a system like Epic or Allscripts and take that information and load it into the electronic medical record so that billing was able to see and coding was able to be done, all from information that was put into the electronic medical record remotely. We also had the advantage that our desk phones worked through our computer system. So you could pick up your desk phone and take it home with you and plug it into the computer system that you had. And that way, when phones were ringing off the hook in the office, remote employees could answer them as well. So we didn't have that issue where the handful of essential employees left in the office were stuck answering all the phone calls. Our extensions also worked. So you could pick up your phone and transfer a call to a pharmacist or transfer to the warehouse when a call came in from a patient. It worked really well. It helped to assist with patient inquiries and keeping us not letting a patient sit on hold, being able to answer a question just as if we were in the office. Next slide, please. Having said that, we could take our phones home, didn't fix all of our communication issues though. I think we found communication among employees to be one of the most difficult things that we had to deal with people in all different locations. Usually you're sitting in the office and you can sort of overhear somebody else's conversation. So you know that that delivery is going today, or you know that Mr. Smith's in the hospital, or whatever's going on with patients, because you can overhear the conversation in the office. But with everybody in different locations, that wasn't happening. So where one person knew something, everybody else didn't know it, like we would have if we were all in the office together. So there were several methods that we used to overcome that communication issue. The first one being that we used an instant messaging system. And the example I'll give you is Microsoft Teams, because that's the one that we used. Everybody in the office was on Teams. And outside of the office as well, our liaisons, our nursing staff, everybody was on Teams. So when a patient was hospitalized, they put a message in, the liaison or whoever would put a message in Team and everybody saw it. It does get cumbersome after a while, all the messages going in and out of Teams, but it does keep you informed of what's happening with all the patients that are on service. Before COVID, we would do a morning huddle via conference call with our sales team so that everybody knew what referrals were potentially coming out that day, who was rehospitalized, who was having issues with their insurance, all of those things that we all talk about on a daily basis, who called on call last night, so on and so forth. We found with people working remotely that one huddle a day was not enough. We needed two, because by the afternoon, everything had changed. The liaisons were also working from home, so they were handling everything telephonically. And so we would regroup again, 3 o'clock in the afternoon, and we got a recap of who really was going home that day. And that way pharmacy had a couple of hours to get deliveries out the door that needed to go. We have used an online nursing scheduling app, and everybody in the office has access to that as well. So we continued using that online nursing app, and pharmacists were able to see when a nurse saw a patient, so they knew when to start looking for labs, or when a patient was going to be seen, so they knew when to get the IVIG out there, or the Remicade, or deliveries for a new referral. So that online scheduling helped us a lot also. In our office, we used a whiteboard for referrals. So anytime that you had a new referral, it got written up on the whiteboard. Everybody knew when that patient tentatively was going, who was going to be the nurse or the nursing agency. And so those of us who weren't working in the office didn't have visibility to that whiteboard. So somebody in the office took a picture of it before each huddle, and they sent it to those of us who needed to see the whiteboard. It was sort of a cumbersome process, but it worked. A couple of us had our own whiteboards at home that we kept up to date with the one in the office. The other thing that we did was we set up electronic access with the different labs, with LabCorp and Quest, so that we weren't dependent upon a fax coming across for us to see what the patient's lab results were, but we were able to get them online. Next slide, please, Ryan. Then we started looking at tactics to keep those essential employees infection-free. We've defined them as being essential. We need them to be in the office and not out sick. So we had hand sanitizer at each door, and there was big signs on our door that said, when you enter, please make sure that you either go immediately to a sink and wash your hands, or you use the hand sanitizer. Everyone had hand sanitizer at their desks. Everyone's temperature was taken as they entered the building, and anybody who had a fever was not allowed in the building. All office staff wear masks in the office at all times. Entry to the branch was limited to only those essential employees. So as I mentioned earlier, the nursing staff, field nurses were kept out of the office. Couriers, drivers were kept out of the office. There were no in-services being done by drug companies. Nobody was bringing us lunch or cookies and cupcakes. So I think we all lost a little weight during COVID. But we also provided disinfectant wipes to all employees so that they could clean their workstation at the beginning and the end of every day. We weren't running through the office, sharing each other's phones and sitting down at someone else's workstation. We tried to stay on our own phones at our own desk with our own keyboards. We did practice social distancing with employees seated at least 6 feet apart. And with half the staff at home, we were able to move around in different cubicles so that nobody was sitting right next to someone else. Next slide, please. We did not, as I mentioned before, allow any non-employees in the office. As I said, no face-to-face in-services. That didn't mean that they stopped. We did get remote in-services from many of the drug companies, which worked just as well, and they actually did send us lunch. We stopped our cleaning service from coming in, which redefined other duties as assigned for employees left in the office when it came time to clean the bathroom. But we did keep everybody out that didn't need to be in the building. We shipped supplies, as I said, to the nursing staff when they needed it. And we did staff meetings virtually. We have Zoom, we have team meetings. You can do a staff meeting virtually. Actually, I think a lot of the nursing staff was happier to do it that way because it took less time. They didn't have to travel into the office. So they did a meeting and they were on their way to see their next patient. Couriers or drivers called when they were in the back parking lot by the warehouse, and deliveries were passed out the door to them. At that time, we were also able to check and make sure that the couriers were wearing a mask at all times when they were making deliveries to patients, and that they had an ample supply of gloves. We actually heard from patients anytime that a courier showed up or a driver showed up at their house without a mask on, without wearing gloves. We heard about every one of them. So we did, as has been mentioned several times already, we did make sure that all employees that were in contact with patients had sufficient PPE and that they were using it appropriately. And patients reported if they didn't, nurses or drivers. Next slide, please, Ryan. So what happens if somebody in your office tests positive? So if an essential employee has symptoms of COVID, they need to be tested, and they need to stay at home until results of their testing are received. They need to quarantine. Their family members may also need to quarantine. So vice versa, if they have a family member who has symptoms of COVID and has tested positive, they also need to quarantine for at least the 14 days to make sure that they aren't also infected. You want to follow directives from your HR department or the CDC regarding when these employees are allowed to return to work. Some employers require negative COVID tests before the employee can return. I don't believe CDC is requiring that right now, but that's up to your employer to make those decisions as well. Next slide. So what do employers and employees think about remote working? There are surveys for every single thing about remote working, but I only put a couple of them in here. There actually was one yesterday that I read about whether you're more effective if you're dressed in business attire than if you're in sweats, which I thought was a really interesting survey to be taking. But anyway, 98% of people surveyed said that they would like the option to work remotely for the rest of their career. So I think those of us who have had a taste of working from home are thrilled with working from home. A flexible schedule and the ability to work from any location and no more commuting were the top reported benefits. So truly, if I wanted to go to the beach for a week and I had an internet set up there, I can work from the beach for a week if you know, nobody would even know where I was, probably. But not everything was positive. Next slide. The top issue faced by remote workers, David alluded to, was unplugging from work. You don't have defined office hours. The interesting thing about taking your desktop phone home with you is it rings all hours of the day and night. So where your answering service normally picks it up and it goes to the on-call person, you're very tempted to answer that phone when it's ringing at 8 p.m. on your desk, especially if it's in your kitchen or your living room. One of the other downsides was a lack of person-to-person communication. People are lonely at home. There's nobody to talk to during the day. I had a lot of conversations with my dog, but he didn't say much back to me. But that lack of personal communication, you know, the birthday cake for your birthday or ordering lunch out together is a social aspect of working in an office that many people miss. With school systems providing virtual education, children at home could be a distraction. And I want to tell you, some of our huddle calls were very interesting. We knew who was on the phone based on whose kids we could hear in the background and whose dog was barking. So something to consider if you're a person who's making calls to patients. You know, they don't want to hear your kids. And it makes me think about, I don't know if you all remember this, the government employee that was on TV doing something and his kids came scooting in and then his wife came scooting in to take the kids back out of the room. You know, I think children at home can be quite a distraction for remote workers. Next slide, please. So managers worry that productivity and focus will be diminished if people work in more informal settings. I think I'm much more productive at home than I am in the office. There are fewer people that come into my office and talk to me. I'm not being distracted by what we're having for lunch today. And, you know, it just, if you keep the TV off and you really are focused in your office on the fact that you're working from this time to this time, you really can be much more productive at home. Employers worry that if employees are not working in the same physical location, will team cohesiveness and company culture suffer? And I think many of the studies have seen that that isn't happening. Team cohesiveness, you still do Zoom calls together, you still do, you know, working in groups, but you're just not sitting in the same room. One of the other things, I know nurses, we have a saying, and there's always a hand on the hip when we do it, that we've never done it that way before. So we are very tough to change the way that we look at things. And I think longtime company policy is difficult to change in some firms. Though we've never done it that way, philosophy is there, and it's something that we need to be able to get past. So I think that's my last slide. So I would just say that in closing, I think it's going to be interesting as we continue dealing with COVID to see how the workplace changes and whether even after COVID is done, whether people can continue to work from home. It'll be an interesting thing to follow and watch.
Thank you all. Great information, just packed with tips. We do have a lot of questions coming in. I know we're running over, but we're going to run through some of those questions for those who are on the phone, who are unable to stay on a little bit late. This is recorded, and a recording link will be sent to you so you won't miss anything. So just, you know, the first question I think we'll send over to David, and, you know, others clearly weigh in. Did you have a problem with your patients not having smartphone technology to be able to complete those virtual visits?
We really haven't. For the most part, pretty much every patient that we've worked with thus far and we're assessing prior to discharge what kind of technology they do have, as we're doing hospital teaches, and our liaison and home care coordinators are working with those patients. But really, we're looking at, do you have a cell phone that's a smartphone, or do you have a laptop or a computer at home that you can use? Pretty much every patient we've worked with has had that, one or the other. And then it becomes, okay, so now are you able to access it? How easy can we make this? And really with some of the technology out there, it's a matter of sending them an email with the link in it and having them click on that link to access a specific room or a specific meeting. So it's actually worked out a lot easier than what I thought it would work out for us.
Great, thank you. Either of you have anything to add on that, Felicia or Don?
No, we didn't run into an issue either with patients not being able to access.
Great, okay, so maybe I'll ask Felicia or David on this. I know, Don, you covered the compact state extension. Any sense to whether this will become a more permanent fixture?
Meaning working from home or telehealth?
Well, the expansion of the nursing compact, I think, as Don had talked about. Yeah, maybe Don, you have some thoughts on that.
What I read, David and Felicia can weigh in, but what I read on their site is there are a handful of states that are looking at becoming part of that. It helps decrease some of the administrative burden around licensure. Certainly from the individual's perspective, they hold a professional license, that nursing license. It allows them the flexibility. It allows companies with multiple sites to move nurses around a lot easier. But there was also this, especially if you looked at that map, you saw that most of the states in the West, the big states in the West, were not participants who felt that they weren't comfortable with another state's regulation or regulating a nurse practicing in their state. So there's that territorial feeling still out there, but again, I think if these additional states come on board, it's a fairly decent, as you can notice, geographic coverage. West and Northeast tend to be outliers. The Midwest is really a central part of the country as latched onto it.
Great.
Yeah, I would agree with you.
Oh, sorry, go ahead. I was going to say, I think having watched it over the past few years, since they first started this, more and more states have been added each year. So it's become much more widespread than it was when it initially started.
If you look at it, somewhere in the ballpark of mid-30s as far as compacted states already. And then if you look at the pending list, there's probably about another 5 to 10 states that are considering or have pending legislation just waiting for final approval. And I really think that this is probably going to be that tipping point where you're going to probably see all those that have pending legislation they're trying to get passed, probably get those passed pretty quickly. And then I really think the other states are going to have no other choice but to kind of fall into that as well.
Great, thank you. So here's another question, switching gears a little bit, associated with patients who have pumps. So how are you ensuring that the training occurs either remote or troubleshooting for those patients, since it's a little more complex? And then second part of that, is there any opportunity for manufacturers to kind of develop, or should they be developing different types of education that you might use in your own program?
I'll take that one. Having been the nurse on call for the last umpteen years, we do remote pump troubleshooting every single day. Most of the time, I've gotten to the point now where I can hear the beep that the pump is making, and I know what the alarm is, because I've just been doing it for such a long time. So I think remote pump troubleshooting is nothing new. I'm working with a couple of different pump manufacturers as an advisor, and they are trying to develop software that either comes on with the screen and says to the patient, down occlusion, what you should do is make sure a clamp's not closed, make sure you're not sitting on it, those sorts of things. So they are already looking at ways to enable patients to do some of their own troubleshooting.
Perfect. Anything to add on that, David?
No, I agree. I think that the troubleshooting of pumps remotely has been something that has been standard for over the last decade, at least since I've been in my role here. and even prior to that. So I don't think there's anything new with that. And I think to Felicia's point, you do it, and our staff do it so often they get used to the pump, they know how it operates. And we've even gone as far as for new staff coming on board who we know may be doing troubleshooting over the telephone, we give them a pump to take with them and keep in their home. That way they have it in front of them if they need to, and they can kind of use that to help guide what they're directing our patients to do. We also do use camera phone technology as well to have patients take pictures of things, send them to us, and we can upload those pictures into the patient's medical record to kind of prove that, yes, this is what the settings were, or this is what we did with that patient. So there are ways to use that technology for documentation as well.
Great, thank you. Great information. So, and I think Felicia, you may have talked about this in your presentation about using a nursing online app.
Yeah.
And people are just curious as to what app you use to use that.
It's called Team Up.
Great, thank you. Okay, that was our last question for today. Many thanks to McKesson for their generous sponsorship, and to Don, David, and Felicia for sharing your knowledge and expertise with us. As a quick reminder, in order to get CE, please follow the link in the follow-up email to take a short quiz within 24 hours. On deck for the COVID education series is Expanding Oncology in the Home Setting, next Thursday from 12 to 1. Please register at nhia.org. This session is full of information about the advancement to accommodate various oncology protocols at home. Thank you to all our providers and suppliers who are working on the front lines to keep patients safely in their home. We are looking forward to bringing you more education each week during our NHIA COVID series. Take care all and stay safe.
Thank you.
Thank you all.